Hi, everybody. First of all, thanks for having me. Thanks for making some time for me. My name is Ravi Sutaria. I'm a rheumatologist. I was trained academically initially, so my unfortunately my fellowship went a year longer. But since then, I'm very happy to be in private practice with my wife for the last 6 to 8 years. Of course, learning the practice of rheumatology has been a great privilege, but working with my wife, who is a physiatry PMR rehab physician, has taught me a lot of insights, frankly, that we didn't get it trained in our fellowship. You know, not
Wow.
every joint pain requires a shot. Sometimes how we proceduralists like orthopedists or rheumatologists might think. But working with other subspecialists and understanding the power of movement, motion, rehab firsthand through our clinic and our rehab offered, in addition to all the autoimmune therapies that are required in these conditions.
Mm.
Um, we're lucky enough to practice where we grew up. So we work in Queens, the Bronx, New York, Queens, New York, and Long Island, New York. So the patient populations we represent are literally everybody from all over the world, which is kind of like what we feel like as New Yorkers. So that's a little bit about me.
Nice.
Yeah, I
Are
can get
we,
started. Yes,
yeah,
sir.
let's just jump in. I mean, it's really great to hear that you have experience with other specialists. I think that can kind of always color someone's opinion of how they look at, more lifestyle medicine and other things that they help support the lupus community with. So we're excited to hear a little bit more about what you have to share.
Yeah, so exactly that. So transitioning from working with MSK specialists like rehab doctors, like physical therapists, like myself, the rheumatologist, motion is important. Motion is important in everything. It's important for health, for mental health, for life, for diabetes, and especially lupus.
Mm.
Why though? Well, so lupus, as we know, is a not a problem of your skin, your bones, your joints, your anything. It's a dysregulation of your immune system. It's the B and T cells of your body going around looking for things like flu and COVID, and they're finding them, but they're also finding things that they think are flu and COVID. Um, Unfortunately, like the skin, the malar rash, like the joints, the joint pain and swelling, and in extreme cases like the kidneys. What does these things cause and manifest as musculoskeletally? So, as I didn't mention yet, so in my training, I specialized in MSK ultrasound because I
Mm.
was very interested to see what joints, muscles, tendons, and ligaments look like, not just in gout, where it's fairly obvious what we're going to see, a hot joint with fluid and maybe chunks of bone missing, but kind of the subtle changes in lupus, because lupus, unlike rheumatoid, is not an erosive arthritis. You cannot take an x-ray and say, oh, there's the rheumatoid or there's the problem.
Mm.
It would be very subtle changes that things like ultrasound can pick up, and I'll talk about that.
Okay.
So it's a non-erosive arthritis. It's a problem of myalgia muscles, because the inflammation and the attack of these B and T cells not just attacks the joints, the covering of the joints, the synovium, but the muscles and tissues surrounding the muscles. This then leads to inflammation of the muscle and the things that connect the muscle back to bone, tendons, and this causes tendonitis. These
Mm.
are the types of things that somebody may not diagnose you with because it doesn't show up in a blood test or an x-ray. And you may not need an ultrasound to do it. As an academic specialist, of course, I enjoy doing that. But a good physical exam may also highlight that. And in subclinical cases, putting the ultrasound can illuminate a lot of things, which I will certainly touch about.
Okay.
So we talked about B and T cells that attack your body. Um, Another part of the subclinical part of lupus, which really is crazy and really difficult, is that sometimes these abnormal cells don't attack your body. They just go to parts of your body and get stuck there. For
Mm.
example, they can get stuck in your kidneys, and now slowly the kidney slows down or the kidney filtration slows down. It can get stuck in joints, and now you get swelling of the joint that's palpable. Somebody can diagnose, somebody can even inject it. But what happens when they deposit on giant muscles like your shoulder or your low back, the lumbar spine, the oblique muscles? Those aren't going to be very evident to us, but we're going to feel the pain, the myalgia, the lack of flexibility, the lack of the inclusion of stiffness. And then these things in combination basically worsen your fatigue, because the fatigue is coming from the muscle and joint, it's coming from pain, but it's also coming from your immune system, in that the immune system, the bones are working too hard to produce these abnormal cells, and that's compounding this ferocious cycle of fatigue.
Wow.
So how do we break that? So before I get into that, I'll kind of compound with what the ultrasound would show that kind of manifests with some of the things I'm talking about of the muscle inflammation, the tendon inflammation. So a common spot, the golfer or tennis elbow, which way is it? Tennis elbow is this side, the lateral, and the golfer is a common site of tendonitis. If we put an ultrasound on that in lupus, we may not see that the bone is eroded. We shouldn't. And so somebody may say nothing is wrong with you, but when we put the tendon on there, we may see subclinical fluid. I'm not talking about a cup of fluid. I'm talking about maybe 0.1, 2, or 3 cc's of fluid, this much fluid that only an ultrasound would observe. The tendon would then look like it has water, like a dry sponge. Instead of a dry sponge, a wet sponge that's absorbed water. So the tendon is taking on this inflammation, which weakens it. It stiffens it. It acts like a glue. And we can actually see these changes on black and white, basically sonar imagery. We can also, all the tendons and muscles are covered with random things. The joints are covered with one cell layer thick synovium. Unfortunately, in autoimmune conditions, these get recognized as a virus or bacteria and get attacked. This then one thin cell layer, as you can imagine, one thin cell layer is invisible without a microscope, then gets inflamed and thickened and hardened to the point you could see it on ultrasound. And in many people, you could just see it through an exam, visualizing or squeezing it. That's called synovial hypertrophy, and that's a sign of active disease. So even if you're not in pain, not feeling stiff, not limited, we could use those ultrasound findings to justify treating you a little bit better. Finally, the thing that's kind of the hardest to do because it takes the most time is this thing called power Doppler. We can actually measure the blood flow in joints, which kind of sounds stupid to say because many joints don't have blood flow, but they actually have microvasculature. Microvasculature is worse in inflammatory diseases because the body is trying to find ways to get the B and T cells to your joints, thinking that they're attacking a flu or virus. So all of these microvasculatures develop. And that's a really bad thing because it brings more inflammation to your joints. But I want to, and we can measure this by seeing basically blood on a microscopic level flowing to the joints, and that's basically inflammatory cells. So now I want to transition the talk into why movement is essential in lupus, because we're just talking about this power Doppler that's showing these microvasculatures being bringing blood and inflammatory cells. So what's the best way to move blood in any situation? Raising your heart rate, exercise. So while these microvasculatures are pumping those inflammatory cells, if you start exercising, they're not just pumping inflammatory cells. They're pumping rich oxygenated blood with other nutrients that is now flushing out these joints because the highway is open because of inflammation. So now we're overtaking these B and T cell highways and putting in the good cells, oxygen, free radical, antioxidants, all sorts of anti-inflammatory, natural, your own body's blood, as simple as that. So physical activity reduces inflammation, right? In the manner I just explained. And then in a sort of pathophysiological way of actually reducing and downregulating IL-6 and TNF levels. Patients may know IL-6 and TNF because those are what drugs target, like Humira targets TNF, Enbrel targets TNF. So it's important part of this disease process that instead of, just exaggerating, instead of taking a Humira, you can exercise for 30 minutes and get maybe 5% of the effect of that Humira, which adds up when then taken with a drug for these inflammatory conditions.
Wow.
Movement improves muscle mass. This then breaks the stiffness and gluing of these immune composition cell depositions. If they deposit on the joints like we talk about, we get that hypertrophy and swelling, but they deposit on the muscles, we may not see it on a subclinical level, but you just become more contracted over time, more stiff over time. So as you preserve and build your muscle mass, you're actually ripping these immune depositions apart and just making them garbage, which then get picked up by the macrophages, eaten up, and then out the kidneys or otherwise. So this is all just not even approaching your treatments yet. This is all strictly from moving, right? So again, would this cure disease? Of course not. But if one thing does 5%, one thing does 10%, the drug does 60%, all these percents add up to basically hopefully achieving low or no disease activity or achieving long-term success for organs. Of course, the obvious stuff, less stiffness from exercise, fewer flares, down regulation of cortisol, down regulation of the B and T cells, so actually fewer flares. Flares get better quicker. And then, of course, functional independence, which, of course, over time is very important. What types of movement are the best? A rheumatologist will never pretend to tell you this, right? This comes from my wife, this comes from reading journals, and this comes from Google, right? Walking, Tai Chi, yoga, aquatic therapy. I will let the experts talk about that, but this is the point of all this is just, there are many ways to exercise, not just running a marathon or playing basketball or whatever. In my clinic, when we see on the ultrasound tenosynovitis, tendons that might be inflamed, or synovial effusions, fluid building in the joints, we may temporarily offload that joint and tell you maybe for a while not to use it as aggressively. We can splint it with over-the-counter splinting, or we can switch you to water-based activities, which is less resistance and less trauma. Okay. I think that I've heard mentioned before the 20-20 rule, which is 20 minutes of movement broken into segments. And then every 20 days, you assess your progress and tolerance to increase that 20-minute regimen.
Oh, okay.
Many ways to do it. Just these are examples. So let's talk about movement in the context of fatigue and flares and medications. Movement reduces chronic inflammation of chronic inflammatory diseases, which then improves the REM sleep cycle. That's important not just for rest and all the things we've already heard about, but REM sleep is the only times where nerves regenerate. Lupus is a disease that either attacks the nerves directly or deposits on the nerves and slowly affects them and makes them slower. So getting REM sleep is especially important for autoimmune patients. Autoimmune patients are prone to deconditioning because the chronic milieu of inflammation is like basically stagnation at night when you're sleeping, which basically hastens your deconditioning more so than a pace than a non-autoimmune patient. So it's important to just keep conditioned because we can't take weeks and breaks from activity like maybe somebody who isn't suffering from these conditions can just take a month off from doing stuff. I would not recommend that for our patients. So basically, just to summarize, I'm going to skip a little bit because I want to hear some questions, and I think I'm at 15 minutes. So I just want to summarize the kind of medical insights into why all of this makes sense. Yes. Lupus affects connective tissue disease and the microvasculature. Those small blood vessels and chronic inflammation caused by those small blood vessels leads to muscle pain, joint pain, fatigue, and even mental health problems as these cells deposit on the brain and can cause depression and other issues like that. So that's not something we're just kind of like making up, like if you don't exercise, your joints will hurt. Quite literally, if you don't exercise, that inflammatory stuff is going to get stuck there and not flushed out. Steroids, and the one thing I didn't mention, our treatment, right, is in addition to all the drugs we have, we prescribe steroids every day because unfortunately they're important in this disease process. Steroids actually both weaken bone and muscle. So although we're using it to potentially treat a flare, treat a rash, treat organ-threatening disease, it is important today, even as low doses as 5 to 10 milligrams can lead to osteopenia, weakening of the bone, insulin resistance, Cushing's disease, bloating in the stomach and neck area, and then, high blood pressure and all the steroid consequences. So it's important when we use those steroids to especially, exercise. Yeah. MSK ultrasound gives us a window into invisible inflammation. Sometimes that's important because lupus patients, unfortunately, with the lack of availability of newer medicines, kind of stabilize that, you feel like you've reached a state where the disease is not gone, but it's not perfect. So you kind of just accept it and you're on the same treatments. Doing these higher level testings to check for inflammation can then help future plan and say, listen, you're feeling fine, but every time I check these particular joints, there's inflammation in them. So maybe over time we should modulate and not just say, let's just put a drug in it or put a steroid in it, but maybe let's use some turmeric for anti-inflammation. Maybe let's put therapy in this exact area as opposed to the shoulder, which isn't showing those signals. Maybe we ice it. Maybe, we have a regimen of rest, ice, compress, and elevate. So it's not just that we want to see it just so we can throw a drug at it. We want to see it so we can make a plan for it and then keep seeing that if our plan is working or not through imagery. And if it's not working, then yes, maybe we could escalate to medicine, or maybe we could put a steroid in there because we know that works. Mm-hmm. So I kind of want to stop with that because I think it's around 15 to 17 minutes, and I'm happy to take questions.
Awesome. Thank you so much. That was really, really interesting, especially about like the tendonitis and when things will or won't show up on, imaging or a standard blood test. Um, uh, I'm just going to look at the questions here. How can a patient ask for MSK ultrasound? How would you recommend a patient kind of approach their doctor and asking about looking at, getting potential tendon inflammation assessed or getting a special ultrasound? Is that something that patients can ask their rheumatologist about?
Depending on who the rheumatologist is, right? So it's not a part of everybody's training unless people take interest in it. Now, I wasn't certainly the only one. There's a group called US Sonar that trains us. I think there's another group, MSK USA or something like that. So many rheumatologists are coming out with this type of training and interest. There's a shortage of, I'm hearing, it's hard to find a rheumatologist. So to how to find one who has MSK training, looking at their website can show you. I would say if rheumatologists are trained within the last 5 to 10 years, the majority of us have ultrasound exposure. I would say before that, it was optional based on interest and maybe not a part of the practice as we've sort of evolved it to be in our clinic. In my particular situation, I learned a lot of it outside of my training because of my wife, who is a rehab doctor, a PMR, who are actually trained specifically with ultrasound for all 3 years of their training. So I learned and picked up a lot from her and then translated how that affects people with chronic inflammation. Whereas for her, it's more chronic issues,
Sure.
through a ball, tore a tendon, whatever.
Sure.
Stuff like that.
Interesting. Do you ever recommend that lupus patients do PT or work with a specialist like that in your practice?
Absolutely. We'll take it. And again, this might be a little bit just because of my interest, but we'll take that ultrasound finding I'll just use the wrist as an example.
Sure.
And we will, in our clinic, put the patient in therapy with the therapist and explain to them, hey, this is a patient with lupus, that everything is great, but this joint, no matter what, just hurts and is swollen and we see inflammation. So the therapist then, depending on what's appropriate, may do a hot paraffin treatment. We may do a TENS unit. I don't pretend to say what parts of the body get TENS and don't because I'm not trained in that, but we love the TENS because it essentially is shocking the microedema of the microvasculature away. So if we can't fix the problem right now, let's just get it out of there so it's not irritating that area. And hopefully that, with other therapies and icing and massage and light resistance, you can flush it out of the area. Then, ultrasound changes are slow. After, let's say, 4 to 6 weeks of therapy, I may follow up that patient on a regular scheduled visit in 3 months. And then I can, on the bedside, put the ultrasound right back on and just compare the last 2 images and say, hey, you may say you're feeling better. You may say you're feeling the same, but the inflammation has changed this much in a positive or negative way.
Okay. Interesting. That's awesome. Another patient asked or said, I have severe fatigue. Do you recommend other things than exercise for that or exercise first?
Yeah, so fatigue is one of those things that's been the chief complaint of many autoimmune conditions, which we've never really had a great answer for. In the last 2 to 5 years, or maybe the last 2 years, it's actually included as a measure in all drug studies. So fatigue scores, whereas in the past, it might just be a bonus for some drug, just put it in their study. And it was interesting for us to talk about. Now it's in every single study because people are recognizing how important it is. Having said that, there is really no good drug for fatigue. You can lock it through exercise. I'm not going to keep rehashing the same stuff, but
right.
That's super important. And then, we do use a lot of B12. I
Mm,
recommend it taking it as a supplement because smaller doses are more absorbable. I obviously don't get to see my patients that much, so I have no problem giving the 1,000 milligram B12 shot in the clinic. If it's too much, which I often tell patients it would be, you just pee it out.
okay.
But there's no side effects in that way. So many patients do get benefit. So it's a very low risk sort of sub-Q injection that we don't mind giving. But aside from that, I don't know any medical treatments for fatigue. REM sleep,
Right.
exercise, B12.
Okay. Very helpful. Thank you. And do you have time for one more? So someone said, if I'm on prednisone, will that affect my muscle recovery if I start being more active?
It's a very complicated question. It's
Okay.
yes and no, okay? Because the reason you may be on prednisone is that there may be an inappropriate inflammation process happening locally or systemically that needs to stop for the greater picture of the body or wellness. So, in that standpoint, you would certainly require it. But steroids, when you take them orally or intramuscularly, don't just pick what they're going to work on. They sort of affect the whole body. So steroids, while they take away the inflammation in the muscle of lupus, they also cause myopathy. They weaken the muscle through a different sort of steroid cortisol related process. So it's sort of a balance. You need to get the right dose of steroid to quell the inflammatory process, but once that's done, you need to lower the dose or stop it so that your insulin resistance, your increased fat deposition, your muscle atrophy caused by the steroid is then either rectified through stopping the drug or through continuing your physical exercise, your what is it called? Tone resistance
Hmm.
training, excuse me.
Hmm.
And then, if you're supplementing with natural supplements, like just getting protein or eating protein in your diet will help build back these muscle breakdowns that we induce through medication.
Very helpful. Awesome. Thank you so much for your time, Dr. Sataria. We really appreciate it. And if you're interested in learning more about him and his practice, we'll be linking to learn more in the caption. Thank you so much.
Great. Thank you for having me, guys.